Welcome to Horizon Medical Education Podcast, concise, evidence-based audio lessons for clinicians worldwide. For supporting notes, accreditation, certificates, and access to all our free courses, visit our platform at www.horizonmedicaleducation.com. And just as a reminder, this podcast is intended for medical professionals and for educational purposes only. It does not replace clinical judgment or local guidelines. Episode 1, Chronic Kidney Disease. In this episode, we'll be covering the essentials of chronic kidney disease, including global burden, definition, key causes, and how to diagnose and stage it in clinical practice.
I'm Fran.
And I'm Minnie.
And please do give us your feedback on this module.
Our tip today is it's useful to use World Kidney Day to recognise kidney disease, and it also can help you raise awareness and screen for kidney disease in your community.
Yeah, thank you, Minnie. So, why are we talking about it? Well, chronic kidney disease, it's a worldwide public health problem with adverse outcomes of kidney failure, cardiovascular disease, and premature death. And over the past half century, there's been a steady and persistent increase in the global burden of chronic kidney disease. So in the last 25 years, it's risen from the 17th to the 12th as a cause for mortality globally.
That's quite a rise, really, isn't it?
It is a rise, yeah. And if we look at data from the International Society of Nephrology, Global Kidney Health Atlas shows that approximately 1 in 10 people worldwide have a lifetime risk of developing chronic kidney disease, although there are large variations across countries and regions.
Yes, Fran, the global burden of disease, the GBD data, have found that the prevalence is much higher than expected in several regions of the world, in particular Oceania, Sub-Saharan Africa and Latin America. Now, these differences may be due to different causes, but certainly it's driven by hypertension, so that's high blood pressure, diabetes mellitus, which is now very common in many low and middle income countries as well as higher income countries, as well as other factors like HIV and exposure to various nephrotoxins. So these are toxins that particularly attack the kidney. So what is kidney disease?
We define chronic kidney disease as the presence and persistence of any of the following. So an estimated glomerular filtration rate of less than 60 mils per minute per 1.73 meters squared, albuminuria, so that's albumin in the urine of more than or equal to 30 milligrams over 24 hours, or markers of kidney damage. So, for example, isolated proteinuria, so again, protein in the urine, or isolated hematuria, so that's blood in the urine, or structural abnormalities in the kidneys. And because this is a chronic kidney disease, it has to have been present for more than 3 months. So that's what chronic means in medical terms. And it is based and categorized on the estimated glomerular filtration rate, that's your eGFR, and your proteinuria. So, that's quite complicated. And in low and middle income countries, an accurate estimation of this GFR may be difficult given that it hasn't been validated for that demographic. So, for example, HIV is a common cause of chronic kidney disease in sub-Saharan Africa. However, still, the best method for estimating GFR in patients with HIV is yet to be determined.
So that's quite interesting, isn't it?
Yes, yeah, very much so. So, Minnie, are you going to tell us a bit about what our kidneys do?
Yeah, so just very briefly, we'll just go through the function of the kidneys, which I'm sure all of you already know, but it's just worth giving ourselves a little snapshot. So the kidneys make urine, and they make urine to get rid of waste and extra water in the body. And waste may be from food, maybe from breaking down medicines, and also as a byproduct of muscle actions. They're also important in keeping a balance of minerals in the body. The kidneys monitor the levels of minerals in the blood and retain them or excrete them as they need to into the urine. So these are products which are water soluble. Kidneys also form a very important function in controlling blood pressure by monitoring water and salts and balancing them in the bloodstream. They do this by producing an enzyme called renin, and this helps your blood vessels constrict, which increases blood pressure. So high blood pressure can harm your kidneys and lead to chronic kidney disease. Equally, chronic kidney disease can cause high blood pressure in itself. Kidneys are very important in creating red blood cells, and they produce a hormone called erythropoietin, or EPO, and this stimulates the bone marrow to make more red blood cells. They also help keep bones strong by maintaining homeostasis of calcium in the bloodstream, and it is vital for balancing the acid-base balance in your body. We obviously have just mentioned this very briefly, and we're not going to go into more detail of how the kidneys function because it is very complicated. But if you'd like us to cover that in more detail, let us know, and we can always do a module on that.
Brilliant. So going back to chronic kidney disease, I briefly talked about its definition, and there I mentioned this eGFR. So this is how we measure it using the eGFR, which is a blood test, and the proteinuria, which is a urine test looking at the ratio of urine albumin to creatinine. So I'm just going to explain a little bit about this glomerular filtration rate, if I may.
Yeah, brilliant.
So the glomerular filtration rate, the GFR, is a measure of how much blood in milliliters is cleaned by the kidneys in 1 minute. By using a blood test to measure creatinine levels, we can calculate the estimated GFR, known as the eGFR. And it's done using a formula that takes body size into account. So the average adult body size is 1.73 meters squared. A normal GFR is around 100 mils per minute per 1.73 meters squared.
Okay.
So because this average is 100, the eGFR can be seen as a percentage of normal kidney function. However, values as low as 60 are considered normal if there's no other evidence of kidney disease.
Okay, so that was in your definition, wasn't it? That it's the eGFR plus evidence of kidney damage.
Yeah, exactly. I've got a CKD chart that I will run through briefly, and obviously you can look on the transcript. But the eGFR is used to calculate the G stage of CKD. But it takes an average person. So, what is an average person? Who is an average person? So it's going to be inaccurate in lots of instances. So maybe in small women, maybe in people who have more or less muscle. It might vary with age, it might vary with sex, it might vary with ethnic origin. So, for example, it can be falsely low in bodybuilders.
So these are people with a lot of muscle.
Exactly, and falsely high in people with anorexia nervosa, who obviously have very, very little muscle.
Yeah. The other part of the calculation is albuminuria. So this is the urine albumin to creatinine ratio. This urine test, called the albumin to creatinine ratio, or the ACR, looks for signs that protein is leaking into the urine. So this is, as you mentioned, Fran, the albuminuria or proteinuria. And this is an important sign of kidney damage. The ACR is used to calculate the A stage of chronic kidney disease, and that is indicated on the chart that you can see in the transcript. So there are 3 recognized stages of albuminuria. A1, so this is normal to mildly increased urine protein levels, and that is generally lower than 3 milligrams per millimole. A2, this is moderately increased urine protein levels between 3 to 30 milligrams per millimole. And A3, so this is severely increased urine protein levels, and that is obviously higher than 30 milligrams per millimole. Combining this ACR ratio with the eGFR, so that's the estimated glomerular filtration rate, this helps you predict whether your patient's kidney disease is likely to progress, whether they're likely to develop complications such as heart and circulatory problems. And other factors can also be taken into account, for example, age, because as we get older, our kidneys do start to lose function normally. In general, the higher the A stage, so this is of the albuminuria, the more likely it is that you will benefit from blood pressure lowering treatment to protect the kidneys from further damage.
Thank you. If you look at the chart that we've got on the transcript, so this explains the stages of kidney disease. So it has these G levels versus the A levels, and gives you an indication of how likely the chronic kidney disease is to progress if kidney function reduces and urine protein levels increase. So
like a traffic light.
It is a traffic light system, and actually they've done it in green, yellow, orange and red, which actually visually is quite helpful, isn't it? So
it is, yeah.
You are G1, so you've got a normal kidney function, 90% and over. remember how I was saying that you can think of it as percentage, and then A1, so that's normal to very mildly increased urine protein levels, then you're at very low risk of disease progression. So that's, that's your sort of entry level chronic kidney disease. And then that goes all the way on to G5 when the patient's in kidney failure. So less than 15% of the kidney function is remaining. With A3, so just as you were saying, Minnie, that's severely increased urine protein levels. Well, then you're at very high risk of disease progression. And realistically, you're going to, be looking at whether you need some dialysis or something like that. So have a look at that, because it's a really nice visual explanation of what Minnie and I have just talked through.
Absolutely.
So I think what I struggled to get my head around initially is that when I was learning about this many years ago, is that we're talking about chronic kidney disease, but actually very often it's not a problem initially with the kidneys. It's a problem elsewhere, like you were saying.
Right, yeah.
It's the hypertension or the diabetes that is then impacting on the kidneys. So you kind of think, well, why would, if I've got a problem with my kidneys, why are they treating my blood pressure? And it's sometimes quite difficult to explain that to patients, isn't it?
Yeah.
But how interrelated all our body systems and organs are, and the impact that one thing can have on something else.
Well, if you think about your kidneys, they're an incredibly important organ. And so anything that impacts the kidney is going to impact the rest of the body and vice versa.
Yeah, it's extraordinary, isn't it? So if we look a little bit at the causes then, as I've just briefly mentioned, so conditions that are associated with intrinsic kidney damage. So hypertension's the big one. And
so when you say intrinsic damage, you mean these are conditions that cause specifically kidney damage? Like the microvascular problems that you get with diabetes and in the kidneys, which cause, the albuminuria.
And diabetes mellitus, as you said, Minnie, they're the big ones. And as these non-communicable diseases increase, particularly in low and middle income countries, this is why there's an increase in chronic kidney disease. And then glomerular disease. So remember, from all our anatomy, so the glomerulars are within your kidneys. And so these are diseases such as acute glomerular nephritis, and examples of these could include also a Mesoamerican nephropathy or Udinam or Sri Lankan nephropathy. I think, Minnie, you know a bit more about those.
Well, these are nephropathies that are thought to be unknown cause in these areas. The nephropathy is very high, and they've linked it to possibly pesticide use, heavy metals, arsenic, and also infections like leptospirosis, malaria, hantavirus, and also to them being in very hot countries where people are often chronically dehydrated and have high heat exposure. Now, I've just put a link on the transcript to a really interesting article in the New England Journal of Medicine, which talks about these chronic kidney diseases of unknown cause in agricultural communities. So if you're interested, click on that link and have a read of that article. It's really interesting.
That's really interesting, isn't it? We know that current or previous history of acute kidney injury can also cause chronic kidney disease, and that often is triggered by severe intercurrent illness or dehydration, or often I find it linked to medicine. So, maybe you start someone on a non-steroidal anti-inflammatory, or particularly in older people, I find it with a omeprazole. It's happened with my patients a few times. I start someone on omeprazole, their kidneys don't enjoy it, and they go into an acute kidney injury pattern, which resolves on stopping it. Other things that we need to be mindful are, which I mentioned there, are these potentially nephrotoxic drugs. So, there are ones that we know cause this, and some I've mentioned. So aminoglycosides, angiotensin converting enzyme inhibitors, so those are ACE inhibitors, and ARB2s, bisphosphonates, cyclosporin, tacrolimus, diuretics, lithium, mesalazine, and non-steroidal anti-inflammatory drugs are a real classic one and readily available. You mentioned agricultural toxins there, didn't you, Minnie, with this nephropathy, so heavy metals and pesticides. And then unregulated herbal remedies are quite a thing as well. And, that is something that I sometimes forget to ask people what they're buying over the counter. Or, maybe they've been to a herbalist.
Other conditions that can cause chronic kidney disease are associated with an obstructive uropathy. So this is essentially a blockage in the urinary tract. So this can be structural renal tract disease, bladder voiding problems, So this is problems emptying the bladder fully, such as a neurogenic bladder, benign prostatic hypertrophy. So this is a blockage due to an enlarged prostate, urinary diversion surgery, and recurrent renal tract calculi, so recurrent kidney stones.
And then there are lots of illnesses, multi-system illnesses that have potential renal involvement, and examples of these would be systemic lupus erythematosus, so that's SLE, and that can cause a lupus nephritis, vasculitis, and myeloma would be another example.
Also, there's a genetic element, isn't there, Fran? So a family history of chronic kidney disease stage 5 or hereditary kidney disease, such as an autosomal dominant polycystic kidney disease. Then there's Alport syndrome as well, which is a sex-linked recessive disease, which typically causes hematuria, so that's blood in your urine. And there's also a familial glomerulonephritis as well. So if there's a family history, that's going to alert you to be checking your patients sooner rather than later, so you can manage their risk.
Yeah. And then finally, cardiovascular disease and obesity with metabolic syndrome. And again, both of those are on the increase, unfortunately, worldwide.
Yeah. Okay. Let's have a little think about the prevalence. In 2017, the global prevalence of chronic kidney disease was 9.1%. So that equates to about 697.5 million cases.
It's almost impossible to get your head around those numbers, isn't it?
It is, yeah.
Yeah.
So in that same year, CKD resulted in 1.2 million deaths. And as you've already mentioned, Fran, it was the 12th leading cause of death worldwide, having jumped up the chart of causes of death. Additionally, 7.6% of all cardiovascular deaths, so that's 1.4 million, can be attributed to impaired kidney function. So it's not just that people are dying from the kidney disease on its own, it's impacting their cardiovascular system, and in fact they're dying as a result of the cardiovascular disease. So CKD resulted in 35.8 million disability adjusted life years.
These disability adjusted life years, Minnie, these are the sum of years of potential life lost due to premature mortality, so that's death, and the years of productive life lost due to disability. So it's really important, that, isn't it?
Absolutely. And actually, diabetic kidney disease was the leading cause of CKD disability adjusted life years, and that accounts for 30.7% of the total. So that's a lot, isn't it?
So I think the really interesting thing about this is, if you think about the symptoms of CKD, is that usually, moving on to that, usually there are no symptoms of kidney disease in the early stages. So it's not that people are going to be coming to you saying, I don't feel well, I think I've got a problem with my kidneys. It's something that as clinicians we need to be mindful of, because there might be some subtle symptoms, but not that the patient would know. But it's like you're a detective, isn't it, Minnie? We've talked about this before. As clinicians, we're detectives. So, it may not be symptoms that a patient may notice or may relate to their renal system, but there might be subtle symptoms more related to the cause of the chronic kidney disease. So, for example, the symptoms from their hypertension, their diabetes, and their HIV. So, we need to be specifically asking about these. And they may be very general. It may be things like chronic malaise. So that's, tiredness, loss of appetite, poor sleep, poor concentration. So, very non-specific things.
Very non-specific, aren't they? So quite difficult.
Yeah, really difficult to unpick. And then, unfortunately, it's not until you get this worsening CKD stage that the number and the severity of the signs and symptoms actually then increase, and then it becomes much more obvious, almost when it's too late to make these good interventions.
So for CKD patients in low middle income countries, the diagnosis of early CKD is more likely to be missed, partly due to lack of resources, and patients more likely to present for specialist care further along the spectrum of CKD, like you've just been describing, Fran, sort of in stage 4 or 5. And it's described as a crash landing presentation is often the pattern of presentation, and that's used to describe these patients who maintenance dialysis, it has to be initiated in an unplanned and sort of emergency manner.
Yes.
So you really want to be able to intervene sooner if you possibly can. I mean, it's not always possible, to try and prevent people presenting to you in extremis.
Absolutely. And the downside for CKD is that you do need to have access to these blood and urine tests to diagnose it, don't you?
Indeed, yeah.
And, you know, and it may be that you're doing their blood or urine tests for other reasons, and then the results, you know, highlight that there's a possible problem with your kidneys. But, you know, thinking about the crash landing that you've just said there, Minnie, and us trying to avoid it, you know, at these more advanced stages, symptoms can include, so tiredness again, swollen ankles, feet or hands, dyspnea, so that's shortness of breath, feeling sick, and possibly hematuria, so that's blood in the urine, and that might be frank, which means it's visible to the naked eye, or microscopic, so you're only picking it up when you're dipping the urine.
Yeah, and we've just included a little infographic of the symptoms of kidney disease, which might help you remember them when you're seeing your patients. You can put this little picture in your head. So let's talk a bit more about the diagnosis, Fran. How are we going to make a diagnosis of CKD?
So we do a blood test. And if the initial result is abnormal, so that's our eGFR of less than 60 mils per minute per 1.73 meters squared, or 60%, that will prompt us to do a repeat test within 2 weeks to assess the rate of change in the glomerular filtration rate. So if the result is stable, you're going to do a further test after 90 days. So that's our 3 months to then confirm that it is this chronic kidney disease and confirm the diagnosis. And so as soon as you detect that there's an abnormal renal function, you then need to be taking a good history, you need to be examining the patients, and the investigations need to be reviewed, and you need to be checking their urine for this ACR, don't you, Minnie?
Absolutely.
And you know, you're trying to get an idea of the time scale over which the deterioration has taken place and how quick that deterioration is.
Tell us a bit about the tips for diagnosing it, because you've put a rather nice box on the transcript.
Right. So it's just a quick summary, isn't it? I think, you know, we've said it all, but it's just to remind us. So in a patient with this eGFR of less than 60 mils, you shouldn't be saying they have CKD unless there is also evidence of kidney damage. So that is our proteinuria, structural abnormalities on renal imaging. So that would be an ultrasound. Genetic disease, which you mentioned, didn't you, Minnie, about this genetic, or histologically proven disease. So, you know, if they've had glomerulonephritis and they've had a biopsy, you know, I mean, that's sort of tertiary.
It's not something you're doing in primary care.
It is absolutely not something I'm doing in my GP practice. Okay. And then again, to meet the definition, the features must be present on at least 2 occasions and for more than 90 days, because we need that chronicness of it. We mentioned before this eGFR, it is inaccurate in patients with extreme muscle mass. So these are the bodybuilders, of whom I'm not seeing very many, or muscle wasting diseases, which is much more common, isn't it? So if you have, you know, patients perhaps with HIV, patients with eating disorders, patients with TB, or other things that have made them very thin and lose muscle, or in patients who've had an amputation, because that will alter their meter squarage, so they won't be 1.73 meters squared.
Yeah.
And then just think about the patient's hydration. So again, you're talking about this, weren't you, Minnie? You know, in these workers in these agricultural hot climates, they are often chronically dehydrated. And certainly my equivalent, given that it is not hot in Britain, would be my frail elderly who just don't drink, particularly those with dementia. And so eGFR commonly drops when patients fail to hydrate properly. So, you know, get them to drink properly. You know, maybe they've booked in for a fasting blood test, although I use those less and less. So, you know, just make sure that the test you've done is when the patient has been hydrated.
So we've talked about the definition and everything, Fran, but what we're really wanting to know is how fast the renal disease is progressing. And this is defined as a fall in eGFR of more than 5 mils per minute per 1.73 meters squared over a year, or more than 15 mils per minute per 1.73 meters squared over 5 years.
That's really useful to know, isn't it? Because I think looking at my practice, I have a lot of patients who have chronic kidney disease, and most of them, they've had a drop for whatever reason, and then it's just very stable. So, you know, I do check it annually and make sure that, you know, we've got them all the right treatment, and I'm happy with them.
Yeah.
I mean, not happy, but you know what I mean. But the ones that
they're not of concern, are they? If it's
they
stable.
are not a concern. But these ones with the progressive renal disease, these are the ones you really have to have you know, your alerts on for.
Okay, so these patients, we need to be asking them about their systemic urinary tract symptoms. Again, as you mentioned before, we need to review their medications regularly, especially looking at new ones, looking for the non-steroidal anti-inflammatories that they might be taking off prescription, from buying over the counter, ACE inhibitors, ARBs, as you've mentioned, diuretics, antibiotics, and mesalazine. We also need to be assessing their blood pressure, doing urinalysis, which is using a dipstick or sending the urine to the lab for measurements of the albumin-creatinine ratio, palpate the tummy for an enlarged bladder, and look for signs of infection, volume depletion, or volume overload, or fluid overload. So this is edema in feet, hands, face.
Yeah, so you mentioned about dipping the urine, Minnie, there, looking for blood and for protein. So if they are there, like you said, you want to send it to the lab partly to exclude a urine infection as the cause. So you're wanting to be doing a urine culture if possible. And just be mindful that dipstick tests aren't sensitive enough to detect this albumin creatinine ratio. Yeah. So if this is a person that you're diagnosing with CKD, you do need to have a lab to detect that part of it if you have one available. And I appreciate not everyone does. So if the ACR is high, then the urinary PCR, so that's the protein. So the albumin is these very, very small amounts of protein coming through. And then when that quantity becomes bigger and bigger and bigger, it then becomes proteinuria. And that can be used to quantify and monitor it. In the olden days, so certainly when I started out, we used to do these 24-hour urine collections, and we had these massive pots, didn't we? Yeah. And that's just not done anymore because these other tests are so good. And then finally, again, if you have ability to do it, you're going to be organising a renal tract ultrasound if your patient has any of this, this accelerated progression, if they have visible or persistent hematuria, symptoms of urinary tract obstruction, a family history of polycystic kidney disease, an age over 20 years, or this EGFR of less than 30%. So that's less than 30 mils per minute per 1.73 meters squared. So that's a GFR category G4 or 5.
Okay. Let's move on to the complications, Fran. What are the complications from chronic kidney disease? The risk of complications certainly increases as your disease progresses. So this includes things like acute kidney injury. That might, as you've already mentioned, actually, this might initiate or accelerate CKD progression. High blood pressure and dyslipidemia. Hypertension can contribute to the risk of accelerated CKD progression, as we've mentioned, and secondary causes of dyslipidemia may include renal causes such as nephrotic syndrome. And this typically presents with a urine albumin creatinine ratio level of greater than 220 milligrams per millimole.
And in fact, we have a module, don't we, on nephrotic syndrome in children that talks about this in quite a lot of detail. Maybe.
Yeah, absolutely.
Cardiovascular disease, so that includes ischemic heart disease, peripheral artery disease, heart failure, and stroke. So people with CKD are 5 to 10 times more likely to die prematurely than they are to progress to end-stage renal disease. I think that's really interesting, isn't it? So as soon as you say you've got chronic kidney disease, the presumption, and rightly so amongst patients, is my kidneys are going to fail, I'm going to end up on dialysis. But the reality is that for the majority of them, it won't progress that far, but they'll end up dying prematurely of something else, like we've talked about, Minnie. Yeah. So I think that's really interesting, isn't it? That it's 5 to 10 times more likely to die prematurely. Yes. The risk of death rises exponentially as renal function worsens, and it's largely secondary to cardiovascular disease. Yeah. So in England, they've done some economic modelling, and that estimated that in 2009 to 2010, an extra 7,000 strokes and 12,000 heart attacks or myocardial infarctions occurred in people with chronic kidney disease compared with age and gender matched controls.
So another of the complications is renal anemia. Now, we mentioned how important the kidneys are at producing EPO. Hemoglobin of less than 11 grams per decilitre, what is defined as anemia. And this may present with symptoms such as tiredness, shortness of breath, lethargy, and palpitations. And as I've mentioned, this is likely to be due to the reduced production of erythropoietin or EPO and the reduced red blood cell survival and iron deficiency.
And then moving on, so you mentioned this again, didn't you, Minnie, the renal, mineral and bone disorder, how vital the kidney is in maintaining that homeostasis. So it may present with bone pain, increased bone fragility, or extraskeletal calcification, such as in the skin or blood vessels. And it's caused by this disturbed balance of your vitamin D, your calcium, your parathyroid hormone, and your phosphate metabolism, due to impaired regulation of intestinal absorption and renal tubular excretion. And this subsequently causes abnormality in bone turnover and mineralization. And your serum calcium may be low or high initially, with vitamin D deficiency, raised serum phosphate, low serum calcium, and secondary or tertiary hyperparathyroidism, which is seen in progressive CKD.
You do a whole module really on the renal, mineral and bone disorders, couldn't you?
Well, and I was just thinking as I read that, oh my goodness me, hyperparathyroidism is one of the most complicated things to get your head around in terms of all the, the primary, the secondary and the tertiary. Yeah.
So other things are peripheral neuropathies and myopathies, and these can present with paresthesia, so this is pins and needles, a disturbed sensation, sleep disturbance and restless leg syndrome. You may also get malnutrition, and this is often seen in end-stage renal disease due to poor dietary intake and the low albumin, the hypoalbuminemia.
Yeah. And then malignancy, I found this really interesting. I did not know this before I wrote this module, Minnie. So people with end-stage renal disease may have an excess cancer risk, particularly affecting the renal tract and the thyroid gland. Now, the exact cause isn't known, but risk factors may include exposure to immunosuppressive agents and immune dysregulation caused by chronic uremia. Horrid for the patient, but, an interesting topic and really important for us to be aware of that.
So that's implying that the high uremia levels cause your immune system to not function properly.
Exactly.
So that's the dysregulation.
Yeah, yeah.
Okay. And then finally, end-stage renal disease, which is probably quite an obvious complication of chronic kidney disease. So people with chronic kidney disease in stages 4 to 5 may need renal replacement therapy, which is known as RRT when you're reading in the literature. And this comes in the form of dialysis or kidney transplantation, which both in themselves are very expensive treatments.
And often difficult to access, aren't they?
Yeah, absolutely.
We've mentioned this already, haven't we, Minnie? All-cause mortality. So we know the risk of all-cause mortality. So that's dying from anything increases with progressive chronic kidney disease. I thought it might be quite useful if we used a case, Minnie. And so this is, as you mentioned at the start, this is just part 1 of our discussion on chronic kidney disease. So we're going to go on in part 2 and we'll use a case and it will overlap. So Marge is a 62-year-old woman who presents to your clinic for routine hypertension review. Her medical history includes hypertension and a MI, so that's a myocardial infarction or heart attack at the age of 55. She is a smoker and has a body mass index or BMI of 33.
That's high, isn't it?
Yeah, so that would come in the category of obese, Minnie.
Okay.
She is taking amlodipine, which is a calcium channel blocker for her blood pressure, aspirin, and bisoprolol, which is a beta blocker for her heart. And on further questioning, she said she had been buying ibuprofen over the counter for what she felt was long-term arthritis to help her with pain.
Okay, so ibuprofen is obviously a non-steroidal anti-inflammatory drug.
Thank you.
So on examination, you find that her blood pressure is 155 over 90 millimeters of mercury and her pulse is 80. Her heart sounds nice and normal, chest is clear, and palpating her abdomen, you find that it's normal, soft, with no organomegaly or tenderness. She appears to be well hydrated, but when you dipped her urine, you have found 3 pluses of protein. You've done some blood tests, and this shows that she has an EGFR of 28 mils per minute per 1.73 meters squared, or 28%. So that's quite low when compared to the year before when she had an EGFR of 38. Her urine culture was normal, no infection found, and her albumin creatinine ratio, the ACR, was 70 milligrams per millimole, and protein creatinine ratio was 100 milligrams per millimole. So that's equivalent to 1 gram per 24 hours of proteinuria. Now, is that high, Fran?
That is high, Minnie. Yeah. So if we go back to our table, that gives her a CKD stage of G4A3. So we did some other bloods on Marge as well, didn't we? Because we know there are all these other factors that may come from it. So we did some additional blood tests on Marge, and they demonstrated her hemoglobin was 104 grams per litre. That's 10.4 in old money. So she is slightly anemic. So that might well be the renal anemia that you talked about there, Minnie. Her albumin is normal at 38 grams per litre. She has a normal HbA1c, so that's looking for diabetes, so that was normal. Her bone profile was normal, and we did protein electrophoresis, so that's looking for myeloma, and again that was normal, so that's nice. But her GFR has deteriorated by 10 mils per minute, so that's by 26% over the past year.
Seems like I said, isn't it?
Yeah, so she's now in the CKD stage G4A3.
If we look at the chart that you kindly put on the transcript, very high risk of disease progression.
There we go. So, luckily for Marge, we had access to an ultrasound scan. So we did that for her, and that revealed normal kidneys. So, we need to think a little bit about now what we do in terms of her management. What we're going to do in part 2, as I mentioned, we're going to talk about the management of CKD in the longer term and prevention, and carry on with Marge and see where we get to.
So thanks for listening, and remember, you can download the supporting notes, complete the CPD quiz and receive your certificate at www.horizonmedicaleducation.com. If you found this episode useful, please share it with your colleagues and follow us for weekly episodes. Goodbye.